Minister of Health Award winner for cardiovascular research excellence. So it gives me great pleasure to ask Peter to come up and give the Princesses Lecture for 2015. The title of his talk is Mending Broken Hearts. Peter?
Thank you. It's quite an honour to be asked to give this talk. What I want to do is to review recent trends in heart donation and or transplantation, and if I can get this to work, and talk about some of the challenges that face us now in heart transplantation in particular. This slide has been shown already in this symposium, and what it shows is month by month deceased organ donation. And in 2009 we had the establishment of the National Organ and Tissue Authority, and I think it's fair to say that for the first couple of years it struggled to find its feet, but since the appointment of Yale Cass as the CEO of the authority, I think it's done a fantastic job in increasing organ donation, and as you can see from the black dot for September, we're now at record levels of organ donation in the country, and as we heard yesterday, we're getting close to 18 donors per million at a national level, where 10 years ago we were at 10 donors per million. So I think that's been a fantastic achievement, and congratulations to Yale and all the people in the authority for achieving that. And that's clearly had an impact on organ transplant activity. The focus of this seminar is on cardiothoracic, obviously, and you can see from the red bars bilateral lung transplants, and you can see over that period there's been a doubling of transplant activity, whereas the blue bars, which show the hearts, you can see that there's been very little change over that time. So clearly the increase in deceased organ donation has had a big impact in some areas, but very little impact in others. And interestingly, when you look at this slide, you'll also note that in the early 1990s we were doing 120 or thereabouts heart transplants per year, and I think there was part of a worldwide decline in the 1990s, which I've never really understood, and we've never actually quite got back to where we were, but I think there's plenty of potential. If you look at the change in donor demographics over time, that's highlighted in this ANZOD registry data, and what it shows you is the age range of donors in different triennia over the last sort of 9 years. And the thing to note is that most of the increase has been in older donors, and in Australia we would rarely consider a donor over the age of 60, and you can see that a large part of the increase has been in that group of people. So this is a group of donors that we don't access or haven't been accessing, although as we've heard already today, with lung donation they're now going up to 75 years of age, and that's part of where the growth has been in that. One of the things about, and one of the reasons that we are very hesitant in heart transplants about using older donors is this slide here. This is international registry data, and it looks at the risk of dying after a heart transplant at 1 year post-transplant, and you can see that the data has been normalised, so that if you take a 30-year-old, their risk is 1, but by the time you get up to age 60, you can see you've got almost double the risk of dying. And if you go over that, then the risk is higher again. And it's very clear that as donor age increases, the risk of recipient or of a poor recipient outcome increases. And it varies across the world as to the average donor age, and it's particularly in Europe. And again, talking to Arezu Aliabadi, who's here from Vienna, she says this year the average age of donors in Vienna, in Austria, is in the mid-50s for heart transplantation. And you can see that there's been a progressive trend in donor age. This is St Vincent's, our own data, looking back over 30 years since our program has started, and you can see the most recent era, which is in the green bars. You can see a clear shift in donor age. So we're seeing the same phenomenon occurring as we try and increase the donor pool to meet demand. On that issue of ageing donors, we've recently completed a study where we've modelled this in an ageing rat population, where we've subjected rats at different ages to brain death and shown that clearly an age-related phenomenon or an interaction between increasing donor age and increasing ischemic time, and the impact that has on the recovery of hearts, at least in this model. And I'm not going to say any more about that because Gayatri, who's in the audience, is going to be presenting this work tomorrow. So you'll all have to come back tomorrow to hear that. As I said, one of the other major impacts on outcome post heart transplantation is the impact of ischemic time, and again you see a very similar phenomenon as you see with donor age, in that as the ischemic time increases beyond 180 minutes or 3 hours, you can see that the risk of death as you go up to 6 hours again doubles at 1 year post transplant. And again, as we've heard already in previous talks today, in Australia and New Zealand, we sort of lead the world in ischemic time. We have the longest ischemic time, although I know in Canada they face similar geographical challenges to what we do. And you can see here that our ischemic time on average has changed very little. In the last 15 years, we've been sitting at around about 4 hours ischemic time. So that's the average ischemic time for a donor heart in Australia. And one of the things I think that people are beginning to realise is that there is a very powerful interaction between donor age and ischemic time, particularly in heart transplantation, but I think this is also going to be proved in other organ transplants, be it lungs, livers and kidneys, that there is a very adverse interaction between increasing donor age and increasing ischemic time. So this is a UNOS registry analysis which is a few years ago, but it's a very large number of patients. You can see the numbers in the top row. So this is 30,000 transplants. And what they did was divide them according to 3 different donor age categories between less than 20 years, 20 to 33 years, and greater than 34 years. And then you looked on the horizontal bars, the ischemic times that these donor hearts were subjected to. So less than 3.5 hours, 3.5 to 6 hours, and greater than 6 hours. And the intriguing result was that if the donor was under the age of 20, it didn't seem to matter what the ischemic time. These hearts all recovered very well. But even with an increase in donor age 20 to 33, what we'd regard as a very young ideal donor, you can start to see that the survival rate reduces as ischemic time increases. And then when the donor's over 34 years of age, you can see an even more dramatic decline in the survival of these hearts. This is average survival. So again, this shows you very clearly this powerful interaction between these two factors. Now, we've heard a lot today about donor heart preservation and transport. Most of the hearts that we retrieve are on ice. Frank has given a very elegant presentation on his work on hypothermic perfusion, and we, and particularly Rob Labalestier in Perth, at least in Australia, have looked at normothermic perfusion, and I think Rob's group still holds the world record for out-of-body time for a preserved heart with 11.5 hours when they undertook a retrieval from Darwin back to Perth for a donor. Although Andre, I think, is looking to challenge that. We've already seen this or variations of this on many talks today. In terms of our own organ experience with the transmedics, this is the total number that we've retrieved to date, 19 of which 13 have been transplanted, but 6 were deemed unsuitable for transplant, and I'll go into that in detail later. I just wanted to give you a sort of flavour of the sort of hearts that we have been retrieving. We started initially with what we would call marginal brain dead donors, and this is one example. It wasn't the first one that we retrieved, but it's the one I'll show you today. And this was, as you can see, a 34-year-old male donor with a long psychiatric history who tried to hang himself while in an institution. He was found in his room They cut him down, and there was 35 minutes of resuscitation. He had a background history of heavy smoking, including marijuana. You can see that when he was in the intensive care unit, low blood pressure, high heart rate, high doses of vasopressors, a very abnormal ECG, but a normal echo showing mild left ventricular hypertrophy. This heart, understandably, was declined by the home state. This was an interstate offer, and that was despite the home state having an urgent call-out, and this donor would have been suitable for that donor. We took the Transmedic system and retrieved this heart, and Pumad's already shown you, I think, this profile, but this is the lactate profile of this heart on the system, and you can see that for the first 2 hours this heart was going in the wrong direction in terms of its lactate performance, but things turned around, and ultimately after 4 hours of assessment of this heart on the rig, we decided that it was transplantable, and we did go ahead and transplant it. The recipient was a 59-year-old male with cardiac amyloidosis due to a transthyretin gene mutation. There was early graft dysfunction, need for an intra-aortic balloon pump, but this heart recovered very quickly over a couple of days, and this person has done very well and is now close to 2 years post-transplant. This is a second case, a very similar story. Again, a hanging, 30 minutes downtime, prolonged resuscitation, high-dose inotropes, a baseline echo showing normal size but clearly impaired LV function with an ejection fraction of 35%. This was a New South Wales donor. The donor was placed on vasopressin and T3 as per an agreed protocol. The noradrenaline was then able to be weaned. There was a follow-up echo which was reported as normal, so the team went to retrieve this heart. On this occasion there was clearly palpable disease in the left circumflex system. Historically this is a heart that we probably would not have accepted with palpable coronary disease, but we put it on the system. It had excellent lactate profile, so we went ahead and transplanted it. The recipient, the heart worked very well. Coronary angiogram showed very mild disease with only intimal irregularities. A third case, and the last of these cases that I'll present, these, as I said, were all brain-dead donors. A 49-year-old male who'd suffered a massive subarachnoid hemorrhage, also complicated by DVT and pulmonary embolism, multiple strong coronary risk factors, but very stable hemodynamics, an acceptable dose of noradrenaline, an ECG and an echo that were normal. We actually requested a coronary angiogram on this donor due to the risk factors, but it was not able to be performed due to logistic considerations. So we went ahead, and I don't know if this is going to play, but I did play it yesterday, and it worked yesterday, but it's not going to work today. But we're able to do a coronary angiogram on the system and demonstrate this heart had severe triple vessel coronary disease. We sort of knew it by palpation, but it turned out to be the most expensive coronary angiogram that we've ever performed. But it clearly proved the point that, another value to the system. I want to switch track now. I've been talking about marginal brain dead donors up until now, but I guess the main theme of the symposium and the rest of my talk will really be around DCD heart donation. And you've seen this slide on a number of occasions already today, but it really does highlight the significant increase in the number of DCD donors, both in terms of absolute numbers as well as the proportion of the total deceased donation population. And that's clearly had a very major impact on particularly kidney transplantation, but also lung transplantation. The second line there is lungs, and I think we're now beginning to realise that, and we'll obviously hear more about this tomorrow, that the lung is really an organ which seems to do better going down the DCD pathway compared to the brain death pathway. Less recovery of livers and even less of pancreas. And the one organ that doesn't appear on this slide is the heart, and that's all. And the reasons for that have been covered extensively. We've also had a lot of discussion earlier today about the definition of death, and one of the things that I've been hammering over the last 3 to 4 years in public meetings is how we have to stop talking about donation after cardiac death. It's wrong in law, it's wrong legally, it's a misnomer, and we should be talking about circulatory. Well, now I've just heard it should be death after determination by circulatory criteria, or donation after determination by circulatory death. But clearly, I think the point here is that the heart hasn't died in this circumstance. The heart, like other potentially transplantable organs, has stopped working. But if you take it out within a short time frame, you can transplant it successfully into a recipient. There's also been discussion about the different issues that relate to the different pathway to organ donation. So with the brain death pathway, you have a catastrophic brain injury, you have loss of all brain function. You then have the brain death sequelae, and that imposes a certain stress and injury on potentially transplantable organs, including the heart. There's a pro-inflammatory environment. So there are significant issues with the brain death pathway. But from a heart transplant perspective, in the brain dead donor, the heart is beating, you can do an echo, you can do various assessments, you can make a judgment about that heart, and you can then retrieve it. And up until recently at least, the use of cold preservation has served us reasonably well with that pathway. In the DCD context, usually, but not invariably, there is a severe brain injury, but there is some residual brain function, and there's a requirement for withdrawal of life support and or inotropic or vasopressor support if the potential donor is on those treatments. Then there's an obligatory period of warm ischemia. It's of uncertain duration, and as we've heard, it's not that easy to predict progression and how long that will take. And then once you've got an arrested circulation, you then have to ask the question, well, how are we going to assess that heart? Is it viable? Is it recoverable? And how are we going to best preserve it? Again, as we've heard earlier in this today, heart transplantation from DCD donors isn't new. The very first heart transplant, as has been repeatedly stated, was from a DCD donor. That donor was also brain dead, so the closest description would be a Maastricht Category 4 donor. In 2008, there were 3 neonatal DCD heart transplants where the donor and the recipient were co-located in adjacent operating theatres. This created quite a storm of controversy at the time based on the observation time between cessation of the circulation and declaration of death, which in 2 of the 3 cases was 75 seconds. The controversy that followed this report really largely closed down the activity, and the group have only performed 1 further heart transplant in their experience. And David Campbell, who is the senior author on this paper, actually presented an update of their experience in Seoul only last week, and said that there was only the 1 additional one that they had performed in their series. There have been 2 other paediatric heart transplants from DCD donors. One was in Boston and one was in the UK. Neither of those have been published. Both of them, as far as I'm aware, involve transport between a donor hospital to the recipient hospital, and both those outcomes were fatal for the recipient. So I think it clearly shows that, with the exception where the donor and recipient are co-located in the same hospital, transporting hearts on cold storage is a very hazardous approach for these types of donor. We heard about the case in 2009, the case report where the group in Papworth, led by Stephen Large, restarted the circulation in a DCD donor. I remember discussing this case report with various intensive care colleagues back here in Australia, and when I sort of discussed it with them, they made it very clear to me that if we tried to do that sort of thing here, they would walk away from DCD transplantation. So we thought we needed to explore a different pathway if we were going to make this a clinical reality, at least in our country. Some time ago, we set up a pig model of DCD transplantation, and I just wanted to sort of show you the events that occurred during withdrawal of life support. So this is an anaesthetised pig. This is the pig heart at baseline, and you can see the right ventricle, which I'll draw your attention to here. And this is at the point where the blood pressure, the systolic blood pressure, has dropped to 50 millimetres. This is about the 5-minute mark in this model. And you can see this is regarded as the onset of functional warm ischemia for other organs like the lung, the liver and the kidney. But you can see this heart is already clearly struggling. And then there is a period where there is progression to complete circulatory arrest. There's still ECG activity at this time, but the mean arterial pressure and the CVP are now equal. And then there's as we've heard, the standoff period, which varies from state to state, anywhere from 2 to 5 minutes. It is longer in some requirements. But when you look at the heart now, you can see that this right ventricle looks markedly distended. And a number of earlier speakers have highlighted the additional injury that occurs or appears to occur to the right ventricle during withdrawal of life support. And it's only when you infuse cardioplegia at the end of this period that you can sort of arrest the ischemic injury that's going on. And that period, we know, is the warm ischemic time. Now, we've been modelling this in the laboratory, and this is some work by Hong Chi Chu, a surgical PhD student, and he's going to be presenting this in much more detail tomorrow. But what we did in the model was put a pressure in a catheter into the left atrium, into the pulmonary artery, and into the right atrium. And what you can see in these animals as you withdraw life support, this is the pulmonary artery pressure, and you can see that there's this early and significant rise in pulmonary artery pressure and an accompanying rise in the right atrial pressure, which is shown in red. The left atrial pressure, which is shown in green, paradoxically goes down, and Hong will present this in more detail, but I think what this is telling us is that there's a hypoxic pulmonary vasoconstriction that occurs during withdrawal of life support, which imposes an additional pressure load on this right ventricle during withdrawal of life support. The left ventricle is ischemic, but it's actually being unloaded rather than loaded in this process. So there's differential effects on the ventricles. So in working out what the steps were towards clinical heart transplantation from DCD donors, we thought really there were three critical steps to making this a clinical reality. The first was that we needed to minimise the damage that occurs during withdrawal of life support. We needed to optimise the organ preservation during transport, and we needed some way that allowed us to assess the viability of the organ prior to the surgeon committing to transplant in the recipient. So we formulated 3 specific hypotheses to address each of those steps, and this became the subject of a PhD by Arjun Iyer, who's also sitting in the audience today. And the first hypothesis was that pharmacological post-conditioning will reduce myocardial ischemic injury and prolong the tolerable warm ischemic time. The second was that ex vivo myocardial perfusion would provide superior preservation to cold static storage. And the third is that normothermic ex vivo perfusion would allow the surgeon to assess the viability of the DCD heart prior to its implantation. Now, what do I mean by pharmacological post-conditioning? The phenomenon of ischemic conditioning or preconditioning has been around since 1986. And the original experiments here were conducted in dogs, where the investigators were trying to study the phenomenon of pre-infarction angina and what the impact that would have on a myocardial infarct, or the injury caused by a myocardial infarct. And so if you look at the top bar here, this is where in this model they ligated the LAD or one of the circumflex, and then they reperfused after a 1 hour period, so mimicking a clinical myocardial infarct. And then they could measure the amount of contractile dysfunction, arrhythmias, and myocardial infarction. To mimic pre-infarction angina, they imposed repeated brief episodes of ischemia and reperfusion in the period immediately prior to this prolonged period of myocardial ischemia. And the hypothesis was that the amount of damage would be greater if you had pre-infarction angina. And what they found was completely the opposite for that if you'd had pre-infarction angina or ischemia, there was a very powerful cardioprotective effect, which they called ischemic preconditioning. And then in 2002 or 2003, another group from the US, Jacob Vinton Johansson and his colleagues, looked at the phenomenon of post-conditioning, where you had the same 1 hour ischemic injury, but at the point of reperfusion, you did brief episodes of ischemia and reperfusion, and they again found a very powerful cardioprotective effect with this phenomenon, which they called post-conditioning. And this is what we thought was a very similar scenario to what happens to the heart following withdrawal of life support in the DCD donor. It has a prolonged warm ischemic insult, which may be 30 minutes or longer, and we thought this was the ideal scenario to try and exploit this phenomenon if we could do so. Now, the signalling pathways that underlie ischemic pre- and post-conditioning are still debated to some extent, but this slide sort of summarises about 25 years of work by many laboratories around the world. But you can see the various potential mediators of this phenomenon shown here, some of the cell surface receptors and the intracellular signalling pathways. And to summarise it briefly, people talk about the reperfusion injury salvage kinase pathway, which involves particularly PI3K and AKT, and you'll notice eNOS with nitric oxide is part of this pathway, and the so-called SAFE pathway, which we'll hear more about tomorrow, the so-called survival activating factor enhancement pathway, which signals through a tyrosine kinase-based JAK-STAT pathway. And the target for both these pathways seems to be the mitochondrion, and in particular the formation of this so-called mitochondrial permeability transition pore. This is a membrane pore which forms in the mitochondrial membrane in response to calcium overload, free radical injury. And what it does is put a hole in the mitochondrial membrane, and all the contents of the mitochondrium leak out. They activate apoptosis or cell death pathways, or if the process is too florid, you get complete swelling and rupture of the mitochondrium, and then you get necrotic cell death. So this is critical to activating cell death pathways. So for a long time in our lab, we've had an isolated working rat heart model. This is our screening model. You saw an isolated working pig heart before. This is the same thing on a miniature scale with a cannula in the left atrium and another one in the aorta. And anything that we screen and think works well in this model, we then can look in a translational orthotopic pig transplant model. And this slide summarises about 10 years of work in our laboratory looking at various modifications to existing preservation solutions, and the one that we've worked mainly with is Celsior solution. And we've looked at so-called sodium hydrogen exchange inhibitors, which block this sodium hydrogen exchanger, which is a critical pathway leading to calcium overload in the cell. We've looked at various cell surface receptors which act on these cell surface receptors. Neuregulin is one of them. Erythropoietin, which would be much more familiar to this audience, is another agent. And nitric oxide donors, including glycerol trinitrate. And we've been able to show in the isolated working rat heart that using these agents singly and in combination, we can activate various elements of these signalling pathways to induce a cardioprotective effect and mimic this phenomenon of ischemic post-conditioning. And you've already seen this slide earlier today. This was work done by Alistair Watson, who's now in Vancouver. So Alistair was another surgical PhD who went through the laboratory. This is work in an isolated working rat heart where the hearts were subjected to 10 hours of hypothermic storage, so much longer than what would be done in clinical practice, where we used a combination of erythropoietin, GTN and zaniparide. And you can see when these agents are added as individual supplements, very little effect. With combined dual supplements, you see some effect, but when you combine all three together, you get quite a profound cardioprotective effect. I'll draw your attention to this combination, erythropoietin and GTN, because zaniparide and drugs related to it are not available for clinical practice. So in translating this into the laboratory, this is the combination that we've relied on. So our first question was, can we extend the tolerability of the heart, the DCD heart, to warm ischemic time? Can we extend this warm ischemic time and get full recovery? And you've heard a lot of different models presented today, but when we started on this, the question was asked, well, how long can a heart be ischemic for and then recover? And no one had really, we thought, addressed this question in the literature. So we set up, this is our home-based normothermic ex vivo perfusion system, and this is a pig heart on the system that you can see there. So if you anaesthetise a pig and don't subject it to any injury but remove the heart, put it on this system and measure its cardiac output, this is what you see with a normal heart that hasn't been injured over a 4-hour period on this ex vivo perfusion system. If you subject a heart, if you subject it to 15 minutes of ischemia and of warm ischemia, take it out, put it on the rig, and these are hearts that are just stored in standard Celsius solution, you get complete recovery of these hearts. If you wait 30 minutes, which is what a lot of people have been talking about in their models, you can see now that there's quite a dramatic decline in the recovery of these hearts. And if you wait 40 minutes, you see no recovery of these hearts at all. If we looked at our triple supplemented solution and compared that, if we subjected the hearts to 30 minutes of ischemia and then added our supplemented solution, you saw quite a dramatic improvement in the recovery of these hearts. And even at 40 minutes, we could show a significant improvement in the recovery of these hearts that have been subjected to 40 minutes of ischemia. So when you put all those things together, what you can see is that by modifying the flush solution of these hearts, we could buy 10 minutes more of warm ischemic time and see full recovery of these hearts, at least in terms of their function. The other thing that we saw with these hearts, the hearts are subjected to short ischemic times, all recovered in sinus rhythm, whereas the hearts that have been subjected to the longer times, you can see this fibrillating left atrium, they recovered, there were arrhythmic changes as well. And again, when we supplemented our solution, we saw the hearts with these longer ischemic times recover in sinus rhythm rather than in atrial fibrillation. We've heard a lot about lactate in the system, and this shows you the lactate profiles over time. These are the baseline, the normal hearts, and as you can see at the 20 minutes, 30 minutes and 40 minutes, a progressive increase in lactate levels in this normothermic ex vivo perfusion system. And if we again compare our supplemented solutions, this is 30-minute supplemented solutions, you can see that the lactate profiles are being brought back to what we're seeing at 15-20 minutes, these hearts that recovered fully, where these these unsupplemented hearts had much higher lactate levels. And we've already heard about this lactate level of 5 and during normothermic perfusion as being sort of the threshold for viability. So with that series of experiments, as I said, we could buy 10 minutes of warm ischemic time. And as we've heard, that we knew that brought us to the threshold of clinical intervention, because that's the threshold, or that's the time limit that our liver colleagues use in their work. The next step then was to show these hearts were viable, but will they work when you transplant them? And that was the next step to actually take this to the transplant model. Rather than use our home-built system that we had in the lab, we thought in terms of clinical translation, the most effective way the next step was really to use a clinically applicable model, which was the Transmedic system, which you've heard a lot about already today. So we took our optimal cardioplegic solution and we compared a group of hearts that had been stored on this system to those that had been cold stored and looked at that in the transplant model. With this model, to model our clinical ischemic times, which I told you are about 4 hours, we subjected these hearts to 4 hours either of normothermic perfusion or 4 hours of cold storage before transplanting them. This shows you the lactate profiles of the 8 individual hearts that we put onto the Transmedic system after being through this protocol. And you can see that 7 of these hearts all had favourable lactate profiles, but one of them didn't. And I think this is one of the values of this system, that you can use it to distinguish hearts. And this heart looked terrible on the system, whereas all the other hearts looked very good. But the ischemic times and everything else on this heart didn't look all that much different to the other hearts that were recovered. We then transplanted them. We had 2 technical disasters. We had one recipient animal develop malignant hypothermia, which is an anaesthetic reaction which occurs in this breed of pigs, and there's I've never seen a pig survive this. And there's been and we had one where the cardiopulmonary bypass machine broke down midway through, and that's because it was about 20 years old when we were doing the transplant in the laboratory. But we were able to transplant 5 of these hearts, and they were all able to be weaned off bypass and maintained on clinically relevant doses of inotropic support. With the cold stored hearts, we only did 3 of them, and none of them ever looked like recovering at all, and partly for ethical reasons we didn't proceed with that. So the next step then was to, having shown that we could recover these hearts, we could assess them ex vivo, was to take this into the clinic and to start a human DCD recovery protocol. But as I said, the optimal preservation solution, we didn't have zaniparide, so we've only had 2 of the 3 components. But we used ex vivo transport with the Transmedics and ex vivo evaluation. And I approached the intensive care specialists across 10 of the institutions, and I thought I had the slide with their individual names on it, but when I approached all the individuals, including Ray Raper, who's in the room, they were all very enthusiastic about being part of this. They knowing that it wouldn't in any way alter the clinical pathway towards determination of death in these individuals. Everyone was very comfortable with this from an ethical standpoint. So we initially set a variety of criteria, and I went and gave a presentation of what we were planning to do at one of the Sydney Metropolitan Hospitals. And the next day I was called and told about a 62-year-old potential DCD donor. So it was already outside our limit, but we decided, given the circumstances, that we would go and retrieve this heart. This particular individual was a bit like Ray's patient Bruce, who we described this morning. This person had relapsed Guillain-Barré syndrome, who was totally locked in, totally paralysed. He'd been like this for about 6 months, ventilator dependent. It was just fed up and had made it very clear that he wanted withdrawal of life support. But in doing so, he wanted to donate whatever organs he could for transplantation, and if he couldn't transplant them, or if they weren't suitable for that, then for research. And so we were able to at least honour his wish in terms of research, but his kidneys were retrieved and transplanted. But this chap, he didn't receive ante-mortem heparin, but he did undergo withdrawal of life support and progressed to total circulatory arrest in a relatively short time. We collected blood to prime the circuit, which we've heard about earlier, flushed the heart and had it on the perfusion system by 45 minutes. As I mentioned, the kidneys were retrieved. We brought it back to the institute and perfused it on the system for 9 hours, with the last 3 hours in working mode. These were the lactate profiles of this heart, and as we've heard earlier today, the lactate levels started at quite a high level, but were trending down until we ran out of istat cartridges, which these things always happen. We then, but we assessed this in a modified system where we could do functional measurements, and this shows you the systolic pressure and the cardiac output of this heart at different filling pressures. And clearly this wasn't a normal heart, but it was alive. And when we looked at its function, this was in the absence of dobutamine, and this is with dobutamine. And you could see this heart was clearly responding both in terms of chronotropic and inotropic activity. And when we saw this, we knew that these hearts were potentially recoverable. So the question was then, well, what do we do if we retrieve a DCD heart that does meet viability criteria? If the lactate level is less than 5 and the coronary sinus level is less than the coronary arterial level. And so we went back to, we had the marginal heart study in brain dead donor hearts at the time, and we sought an extension or a modification to this, or an amendment to this protocol, and we were fortunate enough to be granted an amendment to enable us to also include within the protocol DCD donors under the age of 40. We decided to be very conservative at this point if we're going to transplant these organs, that had a viable lactate profile on the organ care system. And I particularly need to acknowledge Julie Letts, who was the policy advisor with the New South Wales Department of Health at the time, who helped to reformulate the patient information and consent form. So the fourth DCD donor that we were notified about was a 26-year-old male who'd suffered a profound hypoxic cerebral injury, again in the context of hanging. He'd had an echocardiogram performed 2 days prior to withdrawal, which had shown hyperdynamic left ventricular function. He underwent withdrawal of life support, and as you can see, there was cessation of the circulation quite quickly at 16 minutes, with a systolic blood pressure of less than 50 for the last 9 minutes. There was a 2-minute standoff time, and then we were proceeded with retrieval, as you've seen the protocol quite graphically shown. So 1,500 mils of blood was drained. And with this, for this donor, the heart, lungs, liver and both kidneys were all retrieved and successfully transplanted into recipients. You've seen this already. This is the lactate profile of this donor. Initially, the lactate levels were very high and the function looked very poor, as Kumud showed you in his presentation. But by within the first 2 hours, these lactate levels had fallen to a viable level. Kumud called me at this point, and I wasn't there at the retrieval, and just said, look, this heart looks terrible. I'm just going, as he said, I'm going to bring it back for the valves. And then I went to bed after that, and I kept getting these phone calls over the next couple of hours and text messages. But eventually I responded to one of them when the lactate level was about here. And he said, look, I think this heart's going to be okay. So I sort of quickly got dressed and came in, and we sort of looked at this heart and we said, look, this heart's going to work. So we decided to go ahead and transplant it. As you've heard already, the recipient was a 58-year-old woman. She had a familial dilated cardiomyopathy with a son who had already undergone heart transplantation and a granddaughter that had died from familial cardiomyopathy. She was in intractable functional class 4 heart failure, had multiple admissions while she was on the waiting list. But she was a very straightforward case. She had a low transpulmonary gradient. We were concerned about the right ventricle for reasons which I showed you earlier, and she had not had any previous cardiac surgery. So we thought this was a very straightforward recipient for this heart. Nonetheless, as Kumar has already indicated, the heart was initially stunned post-implant. This shows you the short axis view of the left ventricle with clearly global hypokinesis. And she was initially supported on ECMO for the first 3 days. But you can see that within a week, this heart had fully recovered, and this is now the same view. The ventricle is much smaller and much more vigorous. This is the first biopsy, which was taken on day 8 post-transplant. This is a protocol biopsy as per our usual schedule, and the heart looked completely normal. This is sort of processing artefact, but there was importantly no evidence of ischemia or reperfusion injury on this biopsy. This shows you our total activity of DCD retrievals that we've attended, starting with that first case I showed you in June 2013. We've attended 15 DCD withdrawals, and as you probably heard, there's another one that is going on today. 2 of those withdrawals didn't progress, and it's important to highlight that because it's a major commitment to mobilise the team and the organ care system. And one of those retrievals was interstate, and it's very sort of disappointing to go so far and to come back completely empty-handed. But it's important that we be prepared to do that if we're going to make this a clinical reality. This is part of the clinical reality of DCD transplantation, not just for hearts but for other organs. So we've retrieved 12 of these hearts, and 3 of them were used for research. I think I've updated this slide, but now it should be 13. But there are 10 that we've retrieved with a plan to transplant them. 6 we have transplanted. 2 of them were from New South Wales, 2 were interstate, and as you heard, for 1 in Victoria and 1 in Queensland. So retrieval distances of over 1,000 kilometres in each case. And we've had 2 in-house donors that we've transplanted. 4 of them have not been used. One didn't progress within the 30-minute time frame, and that heart was crossed over to research. 1 did arrest within the 30-minute time limit, but had high lactate profiles. They were actually improving on the system, and I think with more experience, this is a heart that we probably would have transplanted. But given how where we were in our program, or where we are, we thought it would not be good to have a protocol violation of our approved study and run the risk of failure. We've had 2 OCS. This should be malfunctions rather than failure. And this, as Mark said, they're still under review. Whether that's machine error or human error still remains to be determined. But it does highlight the fact that as you introduce complexity in the process, there are more places where it can go wrong. You've seen this slide already. This shows you the donor profile of the 6 that we have transplanted. They've all, with the exception of the first one, they've all been head trauma, variable levels of inotropic support. Only 2 of them had echoes performed prior to that, and an echo in the DCD context is considered an antemortem intervention if you specifically request it. So we don't request it if it hasn't been done prior to referral. These are the recipients who have all received these hearts. This is the first case that I showed you. The third case also had moderate early graft dysfunction, required an intra-aortic balloon pump for the first 2 days, but subsequently has made an excellent recovery. He was sitting in the audience here yesterday. The second case, had a very more straightforward recovery, as have the last 3. And I'm pleased to say that all these people or recipients are alive at follow-up ranging from 5 to 15 months, with 3 of them now over 12 months, and all of them with graft function, which is normal at latest follow-up. We have written up the first 3 of these cases, as you've heard, in the Lancet earlier this year. We did initially send a case report on the first case to the New England Journal. They knocked it back, and when they sent it to us, I wrote a letter back to the editor and I said, look, I think you've misjudged this, because they said they didn't think it was important enough or impactful enough to make it into the New England Journal. But they were going to reconsider it, but we knew that our colleagues in the UK were very close to starting their own clinical program, so we just withdrew the resubmission. And Kumud spoke to the editor of the Lancet, and the initial editor who spoke to him said, well, if you're going to have a public announcement, which we were going to do because the hospital was saying we need to tell the world that we've done this, the initial Lancet editor said, well, forget about publishing it with us. And then we had our media launch at the request of the hospital, and then about a week after that, another Lancet editor contacted us and said, look, after all the hullabaloo settles down, would you be interested in writing up these initial cases? So it was nice to be actually invited to write a paper, an original paper for the Lancet. As you've already heard, the Papworth group under Stephen Large and Harefield under Andre Simon have started their successful programs. As we just heard, Papworth are now up to 9 cases, and they're using mainly in situ ECMO, which I think still has significant ethical issues around it. But the Harefield group have basically used a similar protocol to ourselves, and both groups have used the Transmedic system as the way of transporting and also assessing these hearts. And I had a great sense of relief when I knew that these programs had started, because it felt very lonely for a while, and now that other programs have started, it gives us a sense that there's a real momentum now, and it's great to have this symposium, have people coming to see what we're doing with a view to starting their own programs in other centres as well. As you've also heard today, this has not been without its controversy. And this paper from Jim Tibbles and colleagues was only published only a month ago in the MJA, and this was the accompanying piece that came out in the media, which I said talked about the findings striking at the heart of transplants. And as I said, these aren't findings; these are opinions expressed by these people. And they're very entitled to express their opinions. But you can see how the media can distort the message and how it could all turn very ugly. So look, in conclusion, I would like to, I hope what I've shown you is that donor characteristics are changing. The deceased organ donation is obviously increasing. That's tremendous. But we're seeing more older donors. We're still faced with long ischemic times. And clearly there's been a major increase in donation after circulatory death, and I think heart retrieval from these different groups is going to be critical if we're going to increase heart transplant activity. Traditional cold storage for donor heart preservation really results, I think, in suboptimal outcomes for these different categories. And I think what I hope I've shown is that with a post-conditioning strategy combined with ex vivo perfusion, you can get optimal utilisation of these more marginal donors. This is my acknowledgement slide. It's already been shown by Kumud, but I'd really like to acknowledge all the people in the lab, especially the students who do the work, the clinical colleagues, particularly Kumud, who's led the clinical translation, all the intensive care specialists who really came quite enthusiastically in with the human study, and especially abdominal retrieval surgeons, Debbie Veron, Henry Pleece and Michael Crawford, who really allowed us to come into an existing clinical practice and enable us to undertake that. And I particularly want to single out Debbie, because as we heard earlier this morning, Debbie led the whole review of the donation after what were then cardiac donation guidelines, the New South Wales guidelines. She completely revamped it, renamed it donation after circulatory death, and actually put heart donation into that document. And without that, there's none of this would have happened. So thank you very much, Debbie, and thank you all for listening. Thank you. Yes, no, very happy to take questions.
Maybe I could just start. The two in-house patients that we had for DCD, did we put them on the OCS or did they?
We did. Yeah. And you could sort of, we sort of asked the question, and I think one of the things I didn't say about the paediatric cases, but it was mentioned by one of the earlier speakers, is that in all those paediatric cases there was ante-mortem cannulation, so they had lines put in, and they also had ante-mortem heparin, so it was quite a different sort of scenario, and we don't have those, we don't have the ability to do apply those interventions in New South Wales. The Papworth group, I think, in there, I'm not sure whether they had ante-mortem, any ante-mortem intervention in the donor, which they did retrieve as an in-house donor. But I don't know if Aravinda is still in the room, but no. So I think it's possible, but what I would say is that. At this stage, I think DCD heart transplantation is still in its infancy, and I think we need to absolutely make sure as best we can that these hearts are viable and will work when they're transplanted. And I think the ex vivo perfusion system really gives the surgeon confidence to know that this heart will work.
Looks like you've knocked them dead, Peter.
Well, hope not, but no. Unless they want to become donors.
This is an honorific lecture, and we want to present you a little plaque, and with the Victor Chang medal. And the medal's very fitting because the medal, you can look at it, Peter shows you later, it's got Victor Chang on one side, and then on the other side it's got a dying person giving their heart to a living person, so it's particularly fitting. And there's also a cheque which we'll give you later.
Thanks. Thank you.